Welcome to Advanced Renal Topics for Nurse Practitioners. I'm John Tsai from the Long Beach VA Medical Center and the University of California Irvine Medical School. Today, we will continue our discussion on hyponatremia with more strategies to manage hyponatremia. Let's first recall that the serum sodium that we measure is a concentration, and that the serum sodium concentration is the amount of salt in our body divided by the amount of water in our body that the salt is dissolved in, otherwise known as our total body water. In the case of hyponatremia, the low serum sodium concentration in our body is usually a result of too much excess water in our body. Also recall that the hormone ADH, or antidiuretic hormone, is responsible for determining how much free water is secreted in our urine. So when we think about excess water in the body, we usually want to first know how much free water a person has in their body. You can either do this calculation on an app or calculators online, but the calculation is relatively straightforward to do with a little bit of algebra, and I'll demonstrate that here. Let's take first a 70-kilo male patient with a total body water of 42 liters and a starting serum sodium of 110 milliequivalents per liter. We can think about this patient as being made up of two different compartments, as seen on the right side, one of which is a patient with a normal serum sodium level of 140, and the other compartment being how much water I have to dilute this patient in order to get a serum concentration of 110. In this case, we assume that mass is conserved, meaning that the total volume on the right side must equal the total volume on the left side. In addition, the total sodium molecules on the right side must also equal the total sodium molecules on the left side. Since we don't know the amount of excess free water, we will first label this as X. We know that since the volume of both sides must be the same, the volume of our normal sodium concentration of 140 patient should have a volume of 42 minus X, as seen here in the top left of the figure. We can then calculate the number of sodium molecules on both sides by multiplying the concentration by the volume, as we did in previous videos. In this case, the total sodium molecules on the left side is 110 milliequivalents times 42, which equals to 4,620 sodium molecules. On the right side, our sodium molecules equals 140 milliequivalents per liter times 42 minus X. The free water has no sodium molecules and hence does not contribute any additional sodium molecules to our equation. If we do a little bit of algebra here, you will see that X equals 9 liters, meaning that our patient must get rid of 9 liters of free water in order to get his serum sodium back to normal levels. While you can obtain the same value by plugging in the values in an app, seeing this calculation visually helps us solidify our understanding and will help in understanding the calculations that I'll be introducing in the next several slides. If I went over this a bit too quickly, feel free to pause the video here and review the calculations before we move on. So we can see that in most patients with hyponatremia, the problem is usually an excess of free water. And if we can just remove the free water, then we can improve the serum sodium. This leads us to our first way that we can correct someone's hyponatremia, which is by somehow removing free water from the patient. As is everything in medicine, sometimes this is easier said than done. But this leads us to our first therapy that we can use for hyponatremia. Diuretics, or medications used to remove water from the body, come in various flavors, including osmotic diuretics, which use an osmotic gradient generated in the tubule to drive fluid removal in the kidney, and our traditional diuretics, such as loop diuretics and thiazide diuretics that we use in clinic. Both osmotic and loop diuretics can be used to remove mostly free water from the patient without removing too much sodium, but thiazide diuretics may make the situation worse, and I'll discuss why this is in the next slide. Urea powder is essentially urea that you can ingest orally, and all of it is essentially absorbed in your gut. If you remember from your physiology lectures, urea is also freely filtered in the glomeruli and excreted in the tubules. By increasing the urea concentration in the tubules, an osmotic gradient is created that is more powerful than the medullary concentration gradient that doesn't allow the water to be reabsorbed. In this manner, more water is secreted, allowing the serum sodium to rise slowly over time. It is also interesting to note that urea powder is actually a very old medication, but it was rather disgusting to swallow, as you can imagine it would taste something like drinking urine. However, they've actually made it lemon-lime flavored now, and it's slightly more palatable and tastes like flat Sprite if you ever get a chance to try it. To understand why thiazide diuretics worsen hyponatremia, we actually have to take a closer look at the medullary concentration gradient in our kidneys. The medullary concentration gradient provides a higher concentration gradient towards the inner aspect of the kidneys that allows higher reabsorption of the remaining water in the collecting ducts of the kidneys, as seen on the rightmost aspect of this figure. Reabsorption of water typically relies on two things. First, the maintenance of this concentration gradient, and second, ADH, or antidiuretic hormone activity, that allows the aquaporin water channels to be active to absorb that water. Any disturbance of these two results in an inability to maximally concentrate your urine. As you know, both thiazide and loop diuretics will disturb this concentration gradient, but due to the location of that disturbance, they have variable effects on the body's ability to concentrate urine. In the case of thiazide diuretics, only the distal tubule is affected, and since this is a limited area, the areas of the highest concentration gradient are actually unaffected, and water reabsorption in the setting of ADH presence can continue unimpeded. This means that if you have a high ADH state when you're taking a thiazide diuretic, your body wants to and still can reabsorb all that free water to make a very concentrated urine. The ability to reabsorb free water can sometimes cause your sodium levels to drop. Now, let's take a look at the effects of a loop diuretic. In this case, the loop diuretics affect channels much deeper in the medulla, meaning that the disruption of these channels inevitably leads to its disruption of the medullary concentration gradient. Without the ability to resorb sodium, the kidney is not able to concentrate urine as much as before, and this results in more free water excretion and less reabsorption of water. So because the concentration gradient is disrupted, the body isn't able to absorb all that free water, and hence you are less likely to get hyponatremic over time. This is sometimes a difficult concept to understand, so if you didn't get it the first time, feel free to pause and rewind the video until the concept makes sense. To understand our next treatment options, let's talk about the effect on urine sodium excretion, how this can affect our serum sodium levels. Let's imagine our same 70-kilo patient, and let's say he urinates 2 liters over the course of 24 hours. In addition, let's say in a closed system, and the only input and output that he has are fluids that we give him and the urine that he pees out. If we consider the extreme example where he is NPO the whole day, and we check his urine sodium level from the 24-hour urine collection, and it's, for example, 50, we can do a little bit of math here to figure out what his next day's sodium will be. Here, remember on that both sides, the volume and the total amount of sodium must be conserved. So on the left, we multiply 110 by 42 liters to get 4,620 millicoulombs of sodium before he urinates. And in the end, we are left with his final sodium X multiplied by 40 liters plus the 2 liters of urine that he produced that has a sodium concentration of 50 millicoulombs per liter. If we solve the equation for X, as we see here, we get that the patient's final serum sodium is 113 millicoulombs per liter, and that he's actually corrected from 110 to 113. So this figure actually illustrates the point that in patients with hyponatremia, sometimes fluid restricting them or keeping them NPO can actually work to improve their serum sodium. So you can see that fluid restriction is one strategy that we use to manage patients with hyponatremia. Now, fluid restriction has some limitations that I'll illustrate in the next example. In this case, we have the same scenario, but instead of having a urine sodium concentration of 50, I have increased it to 200. If we recalculate our end sodium, you'll see that in this case, the urine sodium level is so high that you are actually removing more salt and water from the patient, and your end serum sodium level is 105.5, which is actually lower than your original sodium level. In this case, we can see that our strategy of fluid restriction does not work, and we may need to use additional strategies that I'll discuss further. If you pause on this slide and review the math, are you able to figure out at what sodium concentration the urine has to be in order for fluid restriction to work? If you figured out that the sodium concentration of the urine is the same as the serum sodium concentration, this is the inflection point that below which your end serum sodium will or will not improve. If you need a bit more time to grasp this concept, please feel free to pause the video and review or try the calculations again with a few more urine sodium concentrations. Now let's start giving our patients some fluids and see what happens to them. In this example, we will give our patient 1 liter of normal saline, and everything else from the previous slide remains the same. Recall that the sodium concentration in normal saline is 154 millicoulombs per liter. Also remember that the volumes on the left side must equal to the volumes on the right side. So if we do some algebra, we can see that in this scenario, our patient has once again ended up with a lower serum sodium concentration of 106.7. One would think that providing a patient normal saline to a hyponatremic patient essentially is providing salt to the patient at a higher concentration, resulting in a higher serum sodium concentration in the end. But in fact, the opposite has occurred here. The reason for this is something called desalination. Similar to where we take seawater and make water with a lower salinity by removing salt, in this case we have removed salt from the body in a process called desalination. The high ADH state resulting in a high urine sodium concentration mandates that salt be removed from the body, and since we have provided a solution that does not contain sufficient salt to meet the demand of the urine, the body ends up having to give up some of its sodium, resulting in a lower serum sodium. You may have heard that clinical pearl that giving someone in SIADH normal saline may actually make them worse, and this is the calculation and illustration to show you exactly how this works. In SIADH, the urine sodium is typically high, and if it is extremely high, like in this scenario, you may end up having a situation where you are in desalination. If the urine sodium is lower than the serum sodium, as we saw in the previous slides, the SIADH is considered mild, and you may be able to get by with fluid restriction alone. Now, how do we correct somebody with a severe case of SIADH? To prevent desalination, we need to give the patient a very high concentration of salt, beyond that mandated to be excreted by the urine sodium concentration. In this case, let's see what happens when we give our patient 3% hypertonic saline. Recall that hypertonic saline has a sodium concentration of 513 millicolons per liter. Doing the math in this case results in our serum sodium going from 110 to 115.4, and as you can see, we have been able to provide sufficient amount of salt to overcome the high urine salinity, and the remainder of the salt stays with the patient, resulting in correction. So here we have illustrated the next way we can correct hyponatremia, which is to give the patient a very highly concentrated salt solution, such as 3%. So we can see in the last slide that if we are able to achieve a high enough salt concentration, then we can potentially correct a patient's hyponatremia. But aside from hypertonic saline, are there other ways we can achieve a high salt intake? Well, yes, and this leads us to an additional way we can correct hyponatremia, which is giving someone salt tabs and fluid restriction. The combination of salt tablets and fluid restriction is essentially trying to achieve a higher salt concentration intake compared to the free water, similar to giving somebody 1.5% or 2% saline. This is obviously very difficult for patients on a low salt diet and should probably not be done for patients with liver or heart failure that require diuretics or anyone who is on a salt restriction, such as patients with hypertension. If you've ever tried to eat a pack of saltine crackers without drinking water, you know how difficult it is to eat a bunch of salt without drinking water. So there is a practical maximum amount of salt tablets of about 6 grams per day that you can give a patient before they end up drinking too much water, and then you're back to square one. So we've done some calculations and shown how different therapies work to correct someone's hyponatremia, but there's a small disclaimer that I have to provide before moving on. First, we are assuming a closed system in our calculations, and as usual, human biology is variable, and patients do a lot of other things you don't want them to do. Keeping somebody NPO for an entire day is also considered torture in some cultures, so these calculations are purely for illustrative purposes only, and I do not recommend torturing any of your patients with the extreme situations that I have presented. Secondly, we have neglected something called exchangeable sodium in our body, and have very simply looked at the human body with a sodium-centric view. The calculations are derived from a concept called the electrolyte-free water clearance, and in order to be more accurate, you should actually include the potassium concentrations in both the serum and the urine. Let's talk about one more treatment of hyponatremia before we call it a day, and that is the V2 receptor antagonist class of medications, also known as the Vaptans. Here there are several of them, but Tolvaptan is the most readily available here in the United States. Recall that in order to absorb free water, you have to have aquaporin channels on the urine side, and if you can block or reduce these water channels, then there's no way of allowing water reabsorption back, and you'll get a water diuresis, otherwise known as an aquaresis. Tolvaptan does exactly that. It blocks the V2 receptor and the ADH that usually adheres to and prevents the translocation of aquaporin channels to the urine membrane. This medication is rather expensive, but works relatively quickly, and you have to observe the patient very closely once you start the medication. Sometimes only one dose is needed to correct a patient's hyponatremia, and this can sometimes reset the patient's system back to normal again. One thing to note about Tolvaptan is that it comes with a black box warning to avoid use in liver failure patients. So we have gone over a lot of material today, but hopefully I've illustrated the pathophysiology behind how some of these treatments for hyponatremia actually work. We typically start off with the least intensive, which is fluid restrictions and salt tablets, and then progress to more intensive and expensive treatments. Hypertonic saline and Tolvaptan should be given in a monitored inpatient setting because of the risk of rapid overcorrection. I didn't talk about two other older treatments that you may see, and these are dimethylcycline and lithium. Both of these have fallen out of favor due to the major side effects that they cause, and especially now that we have much better treatments for hyponatremia. As usual, let's do a quick question to check your understanding of the material today. This one's a bit tricky, so be sure to pause the video before moving on if you can't get the answer immediately. A 66-year-old male with history of heart failure with reduced EF, with an EF of 25 to 30%, and hyponatremia is brought to the emergency room for shortness of breath. He is noted to have hyponatremia to 120 and started on aggressive diuretics. 3 days into admission and after diuresing the patient a net of 10 liters, the patient feels better, but is persistently hyponatremic to 122, and continues to have 1+ pitting edema to bilateral lower extremities. He is then started on urea powder for chronic hyponatremia in addition to his diuretics. Which pattern of urinary electrolytes is expected? Is it low urine sodium and low urine osmolality, low urine sodium and high urine osmolality, high urine sodium or low urine osmolality, or high urine sodium and high urine osmolality? Feel free to pause the video now if you need more time to answer the question. If you answer that both the urine sodium and urine osmolality will be high, great job. This is the correct answer. In this case, recall that while most patients with heart failure have a low urine sodium level, this patient has been on a diuretic, which will affect the distal sodium delivery, and because of this, we expect that the urine sodium to be high. In addition, the patient has also been on urea powder, and if you can recall, urea powder is an osmotic diuretic that pulls water into the tubules by increasing the osmotic gradient. The addition of urea into the urine will contribute to a higher osmolality detected in the urine. Hence, in this case, both the urine sodium and osmolality will be high. That's it for today, but join us next time when we discuss what to do when we accidentally overcorrect hyponatremia and strategies to minimize accidental overcorrection.